I'd like to tell you a little bit about our hospital, Maimonides Medical Center, in Brooklyn, New York, which actually has nearby the oldest zip code in the country, the oldest average age. But you can see our average patient age is 68, but 28% of the population is over age 75. So we deal with a lot of high-risk patients and in tertiary care. But the reason that I'm presenting this is shown on these two graphs here. We had, courtesy of my colleague, Sammy here, the main data collector. The state of New York has an average outcome which is risk-adjusted by hospital, and every hospital gets reported the patient safety indicators of AHRQ. This is our graph, which shows that over time we were a high outlier compared to the average hospital in the state of New York in terms of postoperative pulmonary embolism or deep venous thrombosis. The exact same graph takes place over here, which is the postoperative sepsis. And that is a patient who is not admitted with sepsis, who develops it rather, in the postoperative period, and these are both high mortality situations. So we first attacked the DVT problem, and one of the things that we did was we revised the assessment that we had, the assessment tool rather, and the prophylaxis protocol. We are fortunate to have computer order entry in our hospital, and not just turning your back on people, but it seems that the overworked house staff could find a way to circumvent the assessment and ordering of prophylaxis, and that had to be tightened up by changing the computer program. That was a very important thing. We embarked on an educational effort, just as all the previous speakers had outlined. However, I believe that the educational effort is a hit-and-miss affair, not very effective. What we found would be most effective is what I call accountability. And by that, I mean there were physician-specific report cards with an invitation to sit down with the departmental chair to discuss why you had 2 or 3 patients in the past month that did not have appropriate VTE prophylaxis ordered. My colleagues, of course, like all doctors, especially surgeons, don't believe the statistics when you first report a high incidence of something, because they say, no, it's not my patient, it must be somebody else's. However, this did not pan out. And you can see from this graph here, this is the compliance with the improved ordering and administration of VTE prophylaxis. So that clearly went up, which is what we'd expect. But even more important is the incidence of postoperative VTEs. And this graph shows the dashed blue line is the average New York State risk-adjusted rate of DVTs and PEs. And you can see that we approached that when we were a very high outlier. So we were very satisfied with that. And we made sure that this knowledge was given to all members of the staff at a frequent interval and resulted in definite behavior change. So the sepsis problem is a lot different, a lot more multifactorial, and we have a whole bunch of initiatives here, and I would be hard-pressed to say which one was the most significant, but I'm going to run through them with you. The first thing was we updated our antibiotic protocols and made them weight-based, which we had not had in the past. The medical letter, for example, recommends the antibiotic, but weight-basing was not routinely done until we set up this protocol. The other thing we did was the universal protocol or operative timeout, or the WHO checklist, which take place just prior to dropping the knife. We added antibiotic prophylaxis to that final operating room timeout, so we made sure that that was an appropriate measure. This is one of the surgical care improvement project measures as well. However, we also added the IHI sepsis bundles as order sets into the computer, so that when a patient was admitted, all of these things were in place. But I think more importantly, one of the things that has been stressed about sepsis is the use of bedside lactate testing and reporting. So we introduced that into our hospital, and I think that that has been very beneficial. And not only that, but we've made a lactate of greater than 4 millimoles per liter to be an alert value, which is called to the physician immediately. And as importantly, we added sepsis to the rapid response team activation criteria, so that anybody in the institution who feels there's a post-op patient who's having difficulties and they think it's sepsis, you can call the RRT, rapid response team, to get the treatment started. So the outcome for this is similar to the outcome for DVTs, and that is when people are reminded of their performance. Here, New York State average, risk adjusted, and here was our hospital at 3.5%, which was very high. That was more than double the state average. In the first year, we took a little blip upwards, but made a very significant improvement in reducing the rate of sepsis and our mortality rate in our institution at the same time, as tracked by the National Surgical Quality Improvement Project, which I am the surgeon champion of and works closely with this sort of data. So the message that I would like to leave you is one that has already been made, I think, very effectively. And that is that outcomes and outcome data, which you share with your colleagues, is what's important to drive change. And as you can see on this slide here, severe sepsis kills many more people than myocardial infarction, lung cancer, colon cancer, and breast cancer. And so it's a very important initiative, I feel, that we took place in our hospital. Thank you, and I'd be happy to answer any questions.
No? Same message about outcomes data. Okay, we're doing brilliantly on time. Thanks to all our speakers for being very excellent about it. Let's open the floor for more general discussion. Any general points to draw from this? By saying that actually that your team working together was the key to it, really. And I guess you said there were benefits in a small institution. I guess others of you are talking about larger institutions. It's presumably a bit harder. Does anybody want to comment on that? Joel?
I'm reminded I was on the original DVT task force, and if you will recall that a camel is a horse designed by a committee, everybody said, no, we don't want to take these accepted standards for assessment. After all, we have an opportunity to reinvent the wheel and do it better ourselves. And that wasted about a year of people yakking away and getting nowhere. And I will tell you, and this is the truth, I stood up at the first meeting and I said, we ought to consider that every medical surgical admission to the hospital is a high risk and be given some form of anticoagulation unless they have a contraindication. And that took 2.5 years of circular argument to basically get around to doing that. So that's my experience with trying to influence my colleagues' behavior.
Does anybody recognize that from their own?
Sorry, I did have a question about...
Stand by the microphone. Thank you.
I'm Chris Resnick. I'm with Michigan State University College of Human Medicine. And working with the preclinical students, we have a little principle that is you can't have a rule unless you have consequences for not following the rule. And so I'm just wondering, given this move towards accountability that you're implementing within your institutions, what if you have how do you deal with physicians who continue to be, let's say, obstreperous or resistant to these sorts of initiatives? I mean, you did mention having to meet with them if they're not following protocols, et cetera, et cetera. What happens if you have to continue meeting with them?
Good question.
We send them to Riyadh. No. Where they go missing. No. That's an excellent question. And I can tell you that we've only had 2 physicians who had more than 1 counseling session. And one of those physicians no longer works at the institution. By publishing the names in a public forum, that achieves exactly what it is. But you're right, you know, it's very hard to influence patients, doctors' rather, behavior when it comes to this sort of thing. And it was hard to get people. The first time I presented our NISQIP data, for example, there was uniform saying, no, the data are all incorrect. Yes, other hospitals may be having a problem, but not us. This is our own data. And so you finally have to get them to come around to where they say, okay, yes, you're right, we do have a problem, and we need to address it. I think that's human nature everywhere.
Raymond, sorry, Michael, do you want to respond to that?
Well, I just make one comment with respect to enforcement, I guess, of accountability. I mean, I think clearly you do need rules, and you do need to have some sense of consequences. On the other hand, I think if it's purely a punitive-based system, people will devise workarounds and ways to hide their tracks, probably pretty effectively. And then you're just talking about increasing the enforcement and videotaping people at sinks, are they really washing their hands and so on. Ultimately, I think it's got to be a combination of culture change, leadership, engaging staff, and I think the real question is how do you effectively engage physicians in quality improvement or improving processes, whatever they may be. I don't think there's any magic recipe for that yet. I think a lot of it has to do purely with leadership and having a sense that this is something that everybody needs to take seriously.
Raymond, did you want to comment on that question?
So partly from at least for hand hygiene from our hospital is trying to get the higher-ups to take a shift pay from the physicians who are not compliant. So we're going to take salary out from this is one of the suggestions. The second thing, I think, not physician level, but at least the nurse level, what we try to do is to have the nurses get involved in our projects. So we have, you're going to be a hand hygiene champion for today, or you're going to be head of the bed champion for today. So it's more than just coming as a 9-to-5 work. You're part of the institution now. You're involved in something beyond just patient care. And because a lot of people, if you take, at least for Saudi Arabia, people have, you're coming to Saudi to make money to leave. Basically, this is why. So you don't have an involvement in your work other than making money. So we're trying to change this behavior to have an involvement in your work, to have something beyond just coming 9 to 5.
Our innovation or our change was more born out of the threat of what might happen if we didn't do anything, which was a lot harder to convince staff that this might be the reality because the Scottish Government has committed to sustaining remote and rural health. They've not been very clear on the specifics of the detail of which, but the belief that it will be all right was the biggest inertia to overcome. And now, 2 years later, there are similar institutions to ourselves undergoing significant reorganisation and change and actually under threat of closure. And it's only now that the staff can see the benefit of the innovation. But it was more of the stick was more of what might happen, which was harder to sell.
I'm just going back to what Maureen was saying in her opening presentation. I wonder whether patient expectations actually could have some sort of driving force in managing some of these more complex clinical conditions, because actually, you know, they're sort of rather absent in this, although they're the, you know, they're the victims, if you like, and I wonder whether, you know, their views and their expectations might influence people.
so I wanted to take that one because we have considerable experience. Being a small setting, hospital in a rural setting, it's almost like the expectation is we're a hospice movement as well. And the inertia of patients to be discharged early was considerable, or indeed of their families to support the early discharge, because after all, the hospital can cope. So the education of both patients, but this is where our primary care GP colleagues were phenomenal in the concept I mentioned of admission. You're coming up for an assessment, you're not coming for an admission, and the result of that assessment may be that you don't actually stay the night, and that was one of the biggest obstacles. And it's still, there's considerable work we need to do within our community to continue that education program. But patient groups were involved in our thing right from the get-go.
That's an excellent point that you brought up, and one that when we're talking as a surgeon is much more difficult to implement, but is coming to the fore. And I can just give you a small example. One thing is patient and family expectations sometimes are unrealistic. There was an excellent paper that was published in the Annals of Internal Medicine a few years ago, which was entitled, "What does it mean when the family wants everything done? Does it mean that you have to operate on patients who have virtually no hope of survival?" And this is a cultural change, which, and that's why I think your comment is bang on. I know that there are many places, the paradigm of which is Oxford, where the James Lind group is actually brings in patient-focused groups and asks them, what do you want? Do you need another pain medication, for example, for rheumatoid arthritis? And they all the patients said, no, we need something to combat the fatigue, whereas the drug companies only wanted to bring in that. So I think that this is definitely a very important thing, which will be a lot more important in the future.
Thank you. Been waiting patiently.
This question is directed to Dr. Horovitz, actually. Just a question about, you mentioned the lactate levels are phoned to the physician greater than 4. Are they phoned or are they pushed electronically to phones? Are they like pushed through IT-wise?
No, they are, yes, that's an excellent question. They should be pushed to your iPhone or whatever phone you have. But in our case, this actually involves someone in the lab or someone doing the point-of-care testing to contact the physician. Yeah, so that's, you're right, that's a potential.
And do you push other things such as white counts over a certain level, or is it strictly lactate that you're looking at?
Yeah.
We have a whole menu of required reporting results. The laboratory has it. And we're hoping to acquire this year the telephone capability to push it directly to the provider.
Okay. Thank you.
Thank you. Thanks. I'd like to hear from some of the audience, well, their experiences or ideas for behaviour change, since we've started with that. And maybe patients as part of behaviour change, because clearly patients don't want to die in hospital. That's probably, they've all got that expectation. Any wisdom from any of you? Excellent.
Sorry, my name's Hanine. I'm one of the junior doctors working in the UK at the moment, and kind of working in the front line and doing the things like sepsis prophylaxis and DVT prophylaxis, and seeing what patients' expectations are. And however much post-surgical patients, things like that, however much you may counsel them that clots and infection may be a risk, they will never ever expect it if it ever happens to them. And I think part of it is as junior doctors, having the expectation to communicate to them when we're doing the DVT prophylaxis, actually, why are we asking them, have they ever had a clot, have they ever had a clot before, or are they immobile at home? Actually communicating with them, you know, we are wanting to prevent DVTs in you, so please understand that we're going to put some tight stockings on you, or we're going to give you low molecular weight heparin, and they would be more compliant, we'll drink more water, we'll move around more, and that way, I mean, I don't have any statistics for the hospitals I've worked in, but from personal experience, they seem to kind of be happier with the care they get when they are involved in what we expect them to be involved in.
Thank you.
I was just going to maybe follow on to that and actually reflect onto the keynote speech. We had a lady who was in her 90s and very infirm and immobile and refusing to get out of bed until someone told her, well, if she's immobile, then the only care facility would be a nursing home. And within 2 weeks, she was up and about. So it was what mattered to the patient in that case, which I think is a very good point that you make about the education, what matters, and finding a way of common ground with the patient, and you may find that they engage a lot more.
Any other points? Can I pick up something from your presentation, Patrick, which seemed to be that part of your underlying philosophy, or part of the solution, was to, which I notice happening a lot in the UK at the moment, is to apply senior expertise as early as possible in the process, and also multidisciplinary expertise as early as possible, so that instead of people going to sequences of folk or starting with the most junior member of the team and getting escalated, you apply your most skilled facilities at the first time the patient's seen, or virtually that. Do you want to comment on that?
You mean when the patient's admitted?
Yes.
Yeah. Well, this is.
As early as possible in the process.
Yeah, well, this is where the specialty of acute medicine, I guess, has come to the fore as well, where it's been shown in countless reviews that early consultant or attending physician, the most senior person reviewing the patient, has shown far better outcome. The schematic I showed happens at weekends as well, so that you have both sets of consultants in at the weekends reviewing the patients. I guess because we have very junior staff, we don't have what's called a registrar grade, so the most senior doctor is about 3 years out of graduation, and they are the ones calling the consultant directly, so we actually have no choice but to have senior review very early on. But even the process, though, the process of redesign and change, however, was actually led from the ground up when we got everybody in. It didn't matter how junior you were. We did things like reverse brainstorming. We actually put up, okay, how can we guarantee our hospital is closed in 6 months? And from that we had the target of what to avoid.
Has anybody else got experience of that, of moving more senior input earlier on in the process? Anybody want to share any stories about that? Does that happen in your hospital? Or
it depends on the hospital, I guess. The DGHs and the district hospitals are small hospitals. You do... in the district hospitals, from what I've seen, is you do rely on the middle grades, the non-consultant levels, essentially, to lead the management, and as a junior you're always more comfortable to speak to them than the consultant themselves, and there's always this taboo of, well, you're going to speak to the consultant and it's got to be something really, really important for you to be asking them something. Whereas in the bigger hospitals it seems that consultants are more happy to be involved, I guess. I don't know if it's different attitude or if it's different expectations from them, or particularly in the acute settings there seem to be a lot more consultants around, and from what I've seen, they are very aware of those things like sepsis and DVT, and very keen to make sure that those things are covered. And
anybody else want to raise anything? We're doing well for time. Any last words from any of our speakers reflecting on this discussion? No? In which case I will thank our speakers and ask you to thank our speakers as well for some very excellent presentations. And thank you for being a good and attentive audience with some rather perceptive questions. Thank you very much. Enjoy the rest of the forum.